Hello, and welcome to the Supportive Care Services virtual Lunch and Learn series. We've created a series of Lunch and Learn videos to help you be successful when navigating your cancer journey. Our Supportive Care Services department is here to help you get actively involved in your healing process. For more information about the Supportive Care Services department, please email socialwork@ironwoodcrc.com.
Well, welcome everyone. I am Dr. Heidi Rula. I'm the Integrative Oncologist and Medical Director of Supportive Care Services here at Ironwood Cancer and Research Centers. I am excited that today we have Dr. Bansal with us to talk about prostate cancer. So we are going to go over a lot of the different questions that our patients have about prostate cancer and see if we can, again, make sure that everybody has a good understanding of what this cancer is all about and what treatment may look like. So Dr. Bansal, welcome and thank you for agreeing to join us today.
Thank you for having me here. It's a pleasure.
Yeah, so our patients have a lot of questions about prostate cancer. Obviously, it's one of the most common prostate cancers for men. So I would like to just kind of get started with some of these questions that we have. I think probably to start it off, can you tell us a little bit about the prostate gland? You know, what is it? What is its purpose? Where is it located?
Yes, for sure. So prostate gland, the major function of prostate gland in most of our adult life is to nourish the sperm. So it makes the essential components of the seminal fluid, commonly referred to as semen. It's a small gland, almost the size of a ping pong ball, located between the urinary bladder and the rectum. So that is why it's usually accessible via a digital rectal exam that older men go through to screen for prostate cancer in certain instances. So, but over time, as we age, the role of prostate gland in nourishing the sperm keeps on declining. And after a certain time, it's more, it loses its functionality. And that's why we see more prostate cancer in older men as well.
So you mentioned a little bit about screening of the prostate gland. So what is out there for men to be screened for this particular cancer?
Yeah, good question. So, prostate cancer screening is still mostly PSA based, which is prostate specific antigen. This is a blood test usually offered to patients above the age of 50. It's usually performed either once every year or once every other year based on patient preference. So still, it is the standard of care. Some people combine it with digital rectal examination as part of screening, but certain studies have suggested it doesn't add to a whole lot of prostate cancer diagnosis. So PSA still continues to play the main role in screening overall. And then, if patients have an elevated PSA, then the next step usually is a urology referral for a prostatic biopsy, which urologists perform typically under ultrasound guidance or with MRI guidance. Subsequent to that, there are other newer tests that are coming out in patients above the age of 50 who have high PSA, but previously had a negative biopsy, sometimes referred to as false negative biopsy, or the PSA was falsely elevated. So in the past, a lot of these patients had to go through repeat biopsies with elevated PSA levels. If sometimes when patients have persistently elevated PSA levels, they have to go through repeat biopsies, and it causes a lot of anxiety. So now there are newer tests coming out. Some of these are covered with Medicare and part of standard of care guidelines. Some of them are still part of bigger clinical trials with more data being accumulated. One of the tests that is offered is a PCA3 test, which is a urine-based test. Again, this is not standard of care screening test. It's for patients who have high PSA as standard of care screening, but negative biopsies. So this is a non-invasive urine-based test called PCA3. Then there are tissue-based tests being performed, which are looking at certain genes to identify patients who are higher risk to have prostate cancer. So these patients can go for repeat biopsies, and patients who have lower risk scores on these newer tests can forego biopsies and keep monitoring their cancer with serial PSA measurements. So the field is moving forward, but still PSA continues to be the standard of care test.
I know that there has been some controversy about, whether or not, every man should undergo a PSA screening test. Some of the task force, like the United States Preventive Task Force, and had kind of I guess advised against doing routine screening. What is your position, and how do you advise your patients?
Yeah, it's a very good question. So prostate cancer screening has been controversial because the biggest clinical trials that were done both in Europe and in America were somewhat confounded by patients who were in the control arm that was not supposed to undergo PSA screening. So we could compare them to patients who were undergoing PSA screening so as to come to a conclusion whether it helps or not. So these patients in the control arm were also getting PSA screening done as part of their routine care. These trials started in the 1990s and went on till the early 2000s and enrolled tens of thousands of patients. So a lot of the data came out and subsequently was found to be confounded with that bias. So we since then have had to tackle with this controversial argument whether prostate cancer screening plays a role in preventing death or not, or diagnosing cancer at an earlier age or not. So one of the things, that I do tell patients is that based on the European trial, that we can prevent prostate cancer specific mortality by screening. What that actually means is that if patients undergo screening with PSA tests, their chances of dying specifically from prostate cancer itself does go down, but it may not make them overall live longer based on the data we have. Again, this is also confounded by a little bit of bias, but this is the best we can deduce from the information we have. So that's why it's been controversial. Overall, what I believe in is shared decision making, where I discuss with the patient all the data that is available and help them decide for themselves whether they want to go for screening or not. It is certainly reasonable for some patients to forego screening for prostate cancer because prostate cancer is a slow growing tumor. Overall, some patients may not benefit from screening. Some of the patient specific factors that I look at our family history of prostate cancer. So especially if there were family members with prostate cancer that was diagnosed at less than 65 years of age, I definitely would encourage those patients to consider screening more. African American ethnicity is another reason because we know in African American population, prostate cancers tend to be more aggressive and more prevalent. These patients do present with metastatic or widespread disease more often. So that is another factor. And then certain mutations that can run in families. So if there is known family history or personal history of BRCA mutation or ATM mutation, we know these mutations increase risk of prostate cancer in men. These patients are offered screening, and sometimes they're offered screening at a very young age. I usually start offering screening at age of 40 for patients with known BRCA mutation. So the standard of care age is 50 as cutoff, but for patients with known mutations, the age cutoff is 40 based on some studies. These studies are not very large studies because we are still getting a lot of data, but based on the data we have, 40 years is considered to be a decent cutoff for patients with a known BRCA mutation.
Wonderful. Thank you for that explanation. That really, I think, cleared up a lot of the why PSA may have been advised against, but certainly that gives us a good reason as to why to consider it. What are the signs and symptoms that a man should look for that might, alert them to a possible prostate cancer?
Yeah, so, still because of the widespread use of PSA screening, most of the patients present with asymptomatic cancer, or they do not have any symptoms from their cancer at presentation. But having said that, a huge percentage of patients, especially that I see in my clinic, that a medical oncologist sees present with what's called stage 4 or metastatic prostate cancer, where the cancer has already spread. So the typical area where the prostate cancer spreads to is the bones. So patients can present with significant lower back pain. Sometimes the cancer can start to affect the spinal cord at presentation. So these patients can sometimes present with weakness in their legs, difficulty walking. So these are some of the more relatively less common but more serious presenting symptoms. Sometimes it can be blood in the urine, though that is less common. Sometimes it can just be generalized pain in the pelvic area. Fatigue, tiredness, and weight loss can also be symptoms of prostate cancer. So just something to keep in mind for certain populations above the age of 65 if you're having these symptoms to be considered.
What are the treatment options that are available to a patient with prostate cancer?
Yeah, so that's a loaded question because treatment is so diverse. So I would, to simplify the answer, I would say we can categorize the treatment into treatment for localized prostate cancer or treatment for recurrent or metastatic prostate cancer. So for localized cancer, the main treatment options are surgery or radiation. So this is prostate cancer that is confined to the prostate. The workup in the beginning has not shown that the cancer has spread anywhere. So the main options for these patients are to either go for surgery or radiation. So the surgery is typically nerve-sparing, nerve-sparing radical prostatectomy, or radiation is external beam radiation therapy. These are the typical treatment options that are offered. Then, as far as the comparison between the two is concerned, I get asked this question a lot from newly diagnosed patients, is which is better. There is not a ton of data, but in patients with a specific kind of low risk disease, there was one study that looked at active monitoring of this cancer versus surgery versus radiation. And that study showed that surgery and radiation were comparable in terms of endpoints of disease recurrence. So both the options can be presented to a patient and patients can make the decision. Some of the factors that help make decision is age, other comorbidities that may reduce the suitability for patient to go for surgery, or it could be logistics for radiation. If they cannot come daily for radiation therapy, patients might want to proceed with surgery. Then, as far as treatment for recurrent prostate cancer goes, so patients go for the initial treatment with either surgery or radiation, and then we see that the cancer has come back. Those patients are usually offered treatment, and the main treatment modality is androgen deprivation, which means decreasing the production of testosterone or blocking the effects of testosterone, because we know it is testosterone that drives the growth of prostate cancer. So those patients usually are offered treatment with androgen deprivation therapy. And now we have drugs that have been used in standard of care practice for the last decade almost, that are advancements on androgen deprivation. So they block testosterone more comprehensively, called newer androgen deprivation treatments. And then some patients, if they have widespread disease at recurrence, that is, the disease is affecting their liver, or they have significant tumor burden, can be offered chemotherapy when the cancer does come back, or if it's spread. The typical chemo we use, which is still effective for prostate cancer, is docetaxel, which has been around for a long time. And then, other treatment options in the right nuanced setting can include immunotherapy. Some patients can benefit from targeted therapy. And then there is this new field of prostate cancer treatment that is now emerging for metastatic patients called radiopharmaceuticals. That is an exciting space where there are new drugs coming out, and we expect some new approvals in the near future.
What about active surveillance? Who would be a candidate to just have their cancer watched to see whether or not it's progressing?
Yeah, no, that's a very good question, and a definite option for certain patients. So typical patients that can be offered active surveillance are patients with what we categorize very low or low risk disease. This risk stratification is based on a number of factors. The biggest one is the PSA values, or how aggressive their cancer appears when we look at it under the microscope, something called a Gleason score. So when patients have low risk disease or very low risk disease, that is a low Gleason score and low PSA values, and some other factors, these patients can be offered active surveillance. What that means is that because we know that their cancer is not that aggressive, even though we know they have cancer, it can be just monitored. These patients may require repeat biopsies. They would require monitoring of their PSAs and close clinical follow-up. So it does come with a component of anxiety. It is not for everyone, but it is reasonable for these patients to consider it, because some people will not be comfortable with the idea of knowing that they have cancer and nothing is being done. But studies have shown that for very low and low risk disease patients, it can be monitored safely. What studies have shown is that people can die of some other reason without having to go through prostate cancer treatment. However, for patients with intermediate risk or high risk or very high risk disease, we do not offer active monitoring, especially if we know patients have 5 years or more to live. How we decide that is based on their comorbidities. So if patients have, say, they are on dialysis or they have other significant health issues that are really hampering their life, sometimes we could offer those patients even monitoring. But as a standard of care for patients with higher risk disease, we offer treatment, but lower risk disease can be offered treatment, can be offered active surveillance. It is a nuanced discussion based on a lot of individual patient specific parameters and their other health problems as well.
You touched a little bit on this concept of a Gleason score, and I think a lot of patients would benefit from just a little bit of an explanation of what that Gleason score is. What's a low, what's an intermediate, what's a high risk score, as they're kind of throwing some of this information when they get their diagnosis.
Yeah. So Gleason score is something that a pathologist, a physician who's looking at the cancer under a microscope helps us decide. So they give us a number, which is based on how actively the cancer cells are dividing when we look at it under the microscope, or how cancer cells are appearing. So a low risk score is typically something that is less than 7. So a Gleason score of 6 is typically 5, 6, 6 we see more commonly, is considered a low Gleason score. Something between 7 and 8 is considered an intermediate Gleason score by itself, although it has to be looked in combination with PSA values to actually decide the risk. But 7 and 8 is the intermediate category, and then 9 or higher is typically considered a higher risk Gleason score, which means that the cancer is behaving a little more aggressively when we look at it under the microscope. Chances of the cancer spreading in future are higher as compared to when a Gleason is 6. So that's the typical kind of the risk stratification, but it has to be looked in with combination of other factors, like how many prostatic biopsies are positive out of, let's say, 10 or 12 cores that were taken, how many of them have cancer, and then the PSA values.
So what I get sometimes, confusion for my patients is, so they get this Gleason score, and then there's this whole concept of staging, cancer staging, right? What is a Gleason score versus what a cancer stage is? Can you just do a quick little overview for prostate cancer? What is stage 1, 2, 3, 4?
Yeah, so the typical, so let's say a patient presents with an elevated PSA and they go for a biopsy, and the Gleason comes back as, let's say, a Gleason of 6. And the patient's PSA is less than 10. In these patients, I may not like to stage them with a CT scan or a bone scan, because studies have shown that the chances of these patients having widespread cancer is very low. So I don't look for a stage 4 in these patients. So I might just say, okay, just an MRI of the pelvis to look at how many cancers or how many nodules we are seeing on the prostate, and a Gleason score is good enough. But overall, the staging for prostate cancer, the risk stratification for prostate cancer is more dependent on the PSA values and the Gleason score. And the staging is more, it's not used as much clinically to decide localized treatment anymore, but that is more dependent on how many blocks are involved with cancer, what is the size of the cancer on the MRI, and if there are lymph nodes that are seen on the MRI or not. So if lymph nodes are actually enlarged, we might say clinically this is looking like a stage 3, but the actual diagnosis of the stage is made when patients go for the surgery. We take out the lymph nodes and see if they're actively involved with cancer or not. And that is a different kind of staging called the pathological staging. So I know it gets a little nuanced because there is this whole stratification called risk stratification, which defines patients based on their PSA and their Gleason. And then there is this other way of staging, which is to see how much cancer has spread outside the prostate or not. So to simplify, I would say there is prostate specific variables that help us decide what is the chance of this cancer spreading in future based on the biopsy. And then there is scans that we do at baseline to see if the cancer has actually spread or not. And it's usually considered stage 3 if it has already spread to the lymph nodes. If it has spread outside the lymph nodes, it's considered stage 4. If it is mostly in the prostate, it's stage 1 or 2 based on how many nodules we are seeing. I hope that answered the question.
No. Again, it isn't something. It isn't an answer that's super simple when it comes to prostate cancer. What about kind of looking at their treatment options? I mean, what are the things do they have to kind of think about in terms of the major complications they could experience either from surgery versus radiation? How do they kind of, if they're given both options, I mean, what are the main things they have to think about if they have just radiation as their treatment versus they have surgery?
Yeah, so surgery and radiation, as far as the effectiveness goes, they have been shown to be somewhat equivalent in some studies, although the data is not that extensive. But as far as the side effects go, the main side effects with prostatectomy, there are some immediate side effects in terms of pain, risk for infection, and overnight hospital stay that is required, having an indwelling catheter for a week that restricts mobility. So some of the surgical complications are that exist with most of the surgeries. And then there are some long-term potential complications, including risk for impotence and risk for urinary incontinence that happens with surgery. So these side effects do improve over time. The incidence does go down over time. People tend to improve significantly from what they experience in the first 2-3 months, but that can be pretty anxiety provoking. As far as radiation goes, it has its own gamut of side effects, but doesn't lead to as much incidence of impotence or urinary incontinence. However, it can cause inflammation in the bladder, something called cystitis. Sometimes it can lead to strictures, that is, fibrosis of the urethra, causing some pain. So we do need to be mindful of side effects and need to keep an eye on them. It can cause incontinence of stool occasionally, although there are now modalities to prevent that from happening, such as we place a space or to reduce the incidence of radiation effect on the rectum. But they both come with their own set of side effects, and it is very individual dependent what they are more comfortable, the risk they are comfortable taking. But in general, people tolerate both the procedures. Radiation does have slightly less incidence of impotence, that some people tend to prefer radiation over surgery in that situation.
Can you give just kind of average ballpark, like if you have surgery, what is your chance when you're out that you will have kind of an issue of long-term impotence or long-term incontinence?
Yeah. So the incidence of impotence is very age-related as well. So some studies have shown for patients in their 50s, the incidence of impotence for the first 2 years can be something around 20%. For patients in their 70s, this number can go up to 40 to 50%. So a lot of it is pre-procedural sexual activity, or where the baseline is, because this is a cancer of people mostly in their 60s and 70s or 80s. And then over time, after the first 2 years, some studies have shown that the incidence does drop to single digits. One study showed 1 out of 14 patients only will have persistent impotence after the first 2 years. So it's not that common after the first 2 years, but there is a real risk of long-term impotence after surgery.
And then radiation is, you said it's significantly lower, but still both impotence and urinary incontinence are a potential long-term complication.
Yeah, so incidence of urinary incontinence long-term with radiation can be as low as 1 to 2% based on different studies. So yeah, so the risk is definitely a lot lower with radiation. Statistically, it might be different for individuals. Some patients may tolerate it less than others, but statistically, the radiation-induced incontinence side effects are lower than surgery.
So if somebody chooses radiation, what could they anticipate a course of radiation therapy would look like for their prostate cancer?
Yeah,
how long treatment, how many treatments would they need?
Yeah, so usually the treatments last for 7 to 8 weeks. So it's 5 days a week of treatment. So a total of around 40 fractions in general. And each session lasts for an hour, but most of it is preparing for the radiation. The actual procedure itself is only a few minutes. So yeah, so that is a significant time commitment for certain patients, but that's usually the typical duration of radiation therapy.
And during treatment, I mean, are there a lot of side effects that they have to think about while they're receiving those 40 treatments of radiation?
Yeah, potentially patients can experience some inflammation effects. So some burning when they make pee or pass urine. Some pain in the pelvic area is common. Radiation in general can cause fatigue, tiredness. Some patients can develop infection of the skin at the sites where we are administering the radiation. So we are diligent with those. We keep an eye out for the symptoms, and it's good for the patients to be educated as well to let the physicians know if they are experiencing any of those side effects. Overall, patients do tolerate it okay during the treatment, but some patients do tend to have pain and the infection-like symptoms while getting treated.
Are patients able to kind of continue most of their activities of daily living and work while they're receiving their radiation therapy?
Yeah, most of the patients are, other than the time commitment, they do have to come to the cancer center every day for 5 days a week for almost 2 months. Other than that, people are able to do most of their daily activities. There is no specific restriction as such as to how much or what they can do. People are mostly able to do most their daily activities. Yeah, because of the fatigue, tiredness that most patients experience, some people would advise against strenuous exercise or heavy lifting during that time period, but overall, people do okay.
What would the recovery time look like for surgery if they opted for surgery? How long would they anticipate,
Yeah.
really to be kind of back up and active after a prostatectomy?
Yeah, so typical duration is it's an overnight one night hospital stay if everything goes to plan, and after that, I think people have an indwelling catheter for a few days, and after that, people are advised not to do heavy lifting or very strenuous exercise if their work involves that for at least 3 to 4 weeks. That's the time it takes for the sutures and everything to heal. And after that, people can go back to work. But if some people are working from home, usually those people can continue working in that time frame. So after a month or so, most of the people are back or close to baseline after the surgery.
Now, what kind of follow-up treatment does either a radiation patient, what does that look like versus a prostatectomy patient? What kind of follow-up can you anticipate for their care?
Yeah, so PSA monitoring is very important, and most people go for that after the surgery. We regularly check PSAs at frequent intervals, and hopefully, patients' PSAs go down to undetectable values. But most of the monitoring is PSA based, as PSA is a very sensitive marker for prostate cancer recurrence after surgery or radiation. So any kind of PSA recurrence or uptrend in PSAs does raise the possibility of disease recurrence. So diligent monitoring of PSA is usually done after the surgery or radiation to detect recurrence.
Now, do they require any other additional treatments if you have an earlier or earlier stage cancer? Do they require any other adjuvant treatments besides the surgery or radiation?
Yeah, so certain patients who have higher risk disease may be offered hormone therapy, that is androgen deprivation therapy, that is decreasing testosterone production in the body with the radiation in the beginning. This is again dependent on Gleason score, PSA values, and some patients where the cancer after surgery has been seen to spread. When we look at the tissues that were taken out after the surgery, like such as positive margins, may be offered radiation after the surgery. Or in certain instances, if there is more tumors, like tumor involving the lymph nodes, patients may be offered more aggressive therapy, such as chemotherapy. It totally depends on what we see at the time of surgery on the tissue analysis.
And what about kind of risk of recurrence? If for kind of earlier stage, lesser grade cancers, lower risk cancers, what's the risk that this cancer will return?
Yeah, so the risk of recurrence is pretty low for very low risk or low risk disease with, like you said, low Gleason score or low PSA values at baseline. But it still is a risk. And the thing with prostate cancer is that the recurrence can happen way down the road. I have patients who underwent their initial treatment in the 90s or 2000s, and the recurrence is now just happening. And we are living longer, and in general, the lifespans are increasing. So we do see people in their mid to late 80s or sometimes even in their 90s with PSA recurrence. So overall, the incidence is statistically still pretty low, but it is still a real risk. And as people are living longer, we are seeing more of PSA recurrence after initial definitive treatment, even for low risk disease.
Now, for somebody who's been diagnosed with prostate cancer, I mean, who could they anticipate their care team, should look like? What specialists are going to be involved in their care, and who they will be seeing?
Yeah, so it should be a multidisciplinary approach. So patients could get an opinion from the surgeon and the radiation oncologist, and in most instances, a medical oncologist as well, to look at the pros and cons of all the treatment options, what the side effects in the short term and long term could look like, what the risk of disease recurrence with each treatment modality could look like, and what the follow-up and surveillance plan would look like in future. So I think the treatment team should involve all those three physicians with the support staff as well. And in certain instances, as we are recognizing more and more, genetic counselors are very important with prostate cancer, as more and more mutations are being linked to prostate cancer. And that not only changes patients' own personal treatment options, monitoring options, it also leads to genetic counseling for patients' first degree relatives, or that means siblings or children. So I think the treatment team could include the three physicians as well as support staff, social workers, as well as genetic counselors in an ideal environment.
Wonderful. Well, I think we really covered, a wide array of kind of topics, for our prostate cancer patients here, from screening all the way to all the different possible treatments and follow-up. So I really appreciate you taking the time to give us such great explanations. So thank you again for joining us, and I hope we will all kind of put this out there, and you can see if you have any other questions. We'll go ahead and kind of post those for you. So thank you, Dr. Bansal.
Awesome. Thank you so much for having me. Have a good day.
Thank you for joining us for our virtual Lunch and Learn series. We hope you enjoyed this session. There will be a replay of this Lunch and Learn on the Ironwood YouTube and social media channels. For more information regarding our supportive care services classes and events, email us at wellness@ironwoodcrc.com. Thank you for spending time with us today.